giving you marks. I just want to know what is your understanding of palliative care. That's all.
Palliative care is the care given for terminally ill people.
Okay.
Yeah, who is not going to get a profit about the treatment they have gone. So we have to give care of relieving their pain and whatever their all aspects we have to look after into that so that they will lead into a peaceful thing in the future, madam.
Right. Anything else anybody wants to add?
It's mainly to improve the quality of life.
Quality of life, absolutely. Yes. Anything else? As you already said, that it's a treatment aimed at improving quality of life and mostly in life-threatening issues in terminal illnesses, right? So if we had to look at a definition, if we look at the definition that WHO gives, palliative care is treatment which is aimed at improving quality of life of patients and their families who are facing problems associated with life-threatening illnesses. It prevents and relieves suffering through early identification, correct assessment, and treatment of pain and other problems, whether they are physical problems, psychosocial problems, or spiritual problems. Right? Now, let's move away from this definition a little bit. Instead of theoretically understanding this, let's look at what we do on a day-to-day basis. You are all nurses, you all work in hospitals. Even without actively working in palliative care settings, working as a medical professional and an allied medical professional, you would have witnessed people suffering, right? Every day, we see patients in hospitals. Is it just physical pain that you see? Or is it something more? What is the first thing that you notice about a person who's suffering from an illness? When you look at a person, what do you notice? The first thing.
The person may be depressed, ma'am.
Yes, okay.
Yeah.
And, very simply put, they look unhappy.
Sick and unhappy, yeah.
Yes, they look unhappy. They look emotionally distressed. Some of them might be crying. Some of them might look very scared and they're like pacing in the corridor because they are very restless. Yeah. Yes, that's the first thing you notice. You notice their distress.
Yes, ma'am.
Right? And it's not always to do with physical pain. Now imagine an illness which is either degenerative, terminal, or causing severe pain. What do you think will happen to such a person? What will be the extent of that person's distress? Right? So we realize that the patient is not only in physical pain and distress, but there is also a component of psychological, social, spiritual distress to it. The quality of life is really hampered. Yes, they're unable to do things that they once did so efficiently, things which added value to their life, like earning money, yes, for themselves and their loved ones, feeling good in their mind and body, being able to do things that they loved, going out, meeting their friends, eating what they liked. All these things basically seem like very small things, but they add on to the quality of our life, and that is hampered completely. And palliative care is all about looking into all these other aspects along with pain and symptom management. Right? So we talk about holistic, whole person care. We talk about psychological well-being, spiritual well-being, emotional well-being, and social well-being. Right? So we talk about this, as you see on the screen, total well-being of the person. Yes. Along with that, we should also not forget that the mind-body connection is there, right? It's a two-way connection. Yes, we all agree that the mind-body connection is a two-way connection. So just the way a body affects the mind, so when a person is ill, that person will also be mentally distressed. Same way, the mind also affects the body. So emotional distress will often exacerbate how people perceive pain. Yes, if somebody is anxious, somebody is distressed, somebody is depressed, then highly likely that the pain they feel will also be exacerbated, will also feel like it's more pain than it actually is. Hence, psychological, social, and spiritual well-being will have an impact on the physical well-being also of the person. Again, who is palliative care for? It's not only limited to the patient, right?
Also.
Yes. So we are caring for the caregivers also. We are also looking after the patient, the family, their children. Why? Why are we doing that? Why is the family the unit of care? What do you think? How is that our job, right? Our job is only to look after the patient. Why do we care about the family?
Ma'am, because they are emotionally bound.
Okay. Yes. Very simply.
Because the patient remains with the family for over a time, so that their eating habits and living habits, all we can know from the family members only. And it will be a help if we connect to the family members also, and make them understand what is the disease like, and what we can do for the supportive treatment.
Right, right. So, see, basically patient's symptoms and how the family is coping with the illness is related to each other. Yes?
Yes.
So both need to be addressed because it's healthier for both of them. When there is a life-threatening diagnosis, okay, let's take, for example, a diagnosis of terminal cancer, okay, last stage cancer. It is traumatic for a 37-year-old woman, right? If it's diagnosed for a 37-year-old woman, it will be a traumatic thing for her. Will it also be equally traumatic for her 40-year-old husband? That his wife, who is just 37-year-old, is diagnosed with terminal cancer.
Really?
Yes. What about her 10-year-old child?
Definitely.
Yes. And what about her aging mother, who is probably 70 years old? So when we give a diagnosis, it's not only affecting the patient, it's affecting the entire family. And they're all suffering from some kind of distress. It might be physical, it might be psychological, it might be spiritual, right? And the emotional and physical resources, right from money, right from savings, right from stress management ability, these resources of the entire family are threatened, not only for the patient, but for the entire family. So the impact of the illness is on the entire family, not only on the patient. It is a family crisis. It's not an individual crisis, especially in case of a terminal illness where we know that it's not going to get cured. Yes, when the patient knows, when the family knows that that person is not going to come back from this. Now, again, the patient is not isolated. No? He or she is a part of a family system. So just imagine that a person who is diagnosed and has a family which is very dysfunctional, very chaotic. They are not really looking after him, not really supportive. Will it affect that illness also? Will it affect the person's will to live? Will it affect the person's cooperation with our treatment? Right. So it's also important for us that the family is also a healthy family, a functional family, so that it helps the patient and vice versa. Yes. Apart from that, when we are looking at, you might have seen patients yourselves with patients with terminal illnesses who have spouses suffering from depression or some other psychosomatic symptoms because of the spouses, because their husband or because their wife is ill. Yeah. Losses suffered by the patient are also losses suffered by the family. Say, for example, a patient's loss of role as the head of the family is also the family's loss of a primary breadwinner. Right? In addition to all of this, when a family is taking care of a person who is terminally ill, there is a lot of exhaustion. We all know. Yes, it is really tiring. It is really draining out to look after someone who's terminally ill. There is a lot of stress due to all the caregiver duties. This can lead to burnout. This can lead to compassion fatigue. This can also lead to guilt because sometimes they feel like, oh, I don't want to do this. Yes. So our role is to help them vent out, help to give them some relief from all the stress they have to face as caregivers. Now, you might all agree with me that this is not only a physical illness, that there are other psychosocial issues related to it, and that it's the entire family which faces these issues. But then some of you might have a question about why you need to know about this. Yeah. You are not a psychologist, you are not a social worker, you are not a psychiatrist. Yeah. So what will you do in this? Why do you need to know about all these psychosocial issues? Simply because you need to know, because you can do the needful then. You can identify, you can assess. Wherever required, you can do your bit of support, and if needed, you can refer to a specialist. Now, there is a psychosocial dimension to the work of all professionals involved in palliative care, and understanding the psychosocial issues will strengthen the practice of any professional who is working in this field, regardless of what kind of work you're doing. Considering that you're nurses, you have a very unique role to play in psychosocial support. Particularly, you are the ones that the patient and family are most in contact with on a daily, often long-term basis. Yeah, and being a constant companion, you are in a position to build a trusting relation with the family and the patient. Yes, very naturally. So you are the ones that they talk to, they tell their concerns to, and tell their stories to. Yes, what happened, how it happened, how they felt about it, how the family coped with it. The nurses get to hear all of it, especially when it's a palliative care setting. And never, I mean, you might not actually be able to do anything about it, but never underestimate the therapeutic value of listening empathetically to the story that they are telling you. Yes? Because, you might not, as I said, you need not be able to hand over solutions to them, but just being able to give them a space where they are heard, that is incredibly healing. When I say that, you might be puzzled. How are these patients going to heal? They're terminally ill patients. But there's one thing I'd like to clarify. We're not talking about a cure. Cure is about getting rid of the illness, right? Healing, on the other hand, is not. Healing is an acceptance of the change that the illness is bringing, looking at themselves not as sufferers. Yeah. Basically seeking personal resources that will facilitate the change, that will help them adapt to the change, looking inside and finding the strength to deal with what is happening with them. That is what I mean by healing. Yeah. And you as nurses can promote it in a big way. So let's first look at what are the psychosocial, spiritual issues that can arise in this context, so that you'll be able to identify these in your patients. Secondly, along with that, let's also look at what can be done to assess the extent of distress and treat it. Yeah. So now again, it's not really possible to separate out these issues into psychological, social, spiritual. Yeah. We can only do it up to an extent because these are pretty much overlapping. Okay. So whatever we are discussing, a particular issue, it will have some psychological aspect, some social aspect, some spiritual aspect in varying degrees. So the first thing you're going to look at is communication. You, I think, have already had a separate session on communication, right?
Already has.
Yeah. Okay. So I won't go into the details of it because it's been covered already. So instead of getting into the protocol of how to break bad news, how to communicate and all of that, I'd like to draw your attention to what happens when there is miscommunication about the illness and miscommunication within the family. when we're doing this hurriedly, when we are just, not giving them proper information, when you're not communicating properly, it can cause further problems like arguing. You might have all had patients who come and argue. Yes, because they were expecting something else is happening in the hospital. Non-compliance with treatment, if people have misconceptions about the diagnosis and the treatment. So supporting and educating the family is vital here. It's important that they have an adequate understanding of the illness and the expected process. That we give enough time to address everyone's concerns about it and to help them communicate clearly. That's our job here. Speaking of communication issues within families, even the most healthiest of families, most functional families, find it difficult to talk openly about this. Talk openly about death, talk openly about dying, right? They naturally tend to hide their feelings to protect the family members from feeling hurt. So they might either hide their distress from each other, or they might hide the news in the first place, especially when it comes to children. They might not want to tell children about it. So you might have, in your communication session, you might have spoken about collusion, about how people don't disclose diagnosis to patients. So the intent is actually to try to protect the other person, but that's not what actually happens when there is miscommunication. So, before I began practicing during my training, a major part of my work was with pediatric cancer patients. And I have seen innumerable such parents. Okay, I don't remember seeing a single parent who didn't hide their own sadness and their own fear and pain from their child. They did it to stay strong for their child. Yes. But what happens is children sense hidden restlessness and anxiety. That their parents are hiding something from them is even more unsettling, even more scary for them. So usually there is no choice about whether or not to tell them, because one, they read emotions around them. They notice adults talking in hushed voices and quickly wiping their tears. They respond to body language, second of all. They can see sympathy in people's eyes when they talk to them. Thirdly, they are aware of changes in their routine. They realize that mama doesn't drop me to school anymore. Mama is in hospital. Yeah, or they're not telling me where she's gone, but she's not at home. My auntie drops me to school now. My auntie packs my tiffin. So we feel that if we hide things from children, they won't understand, but they do. And understanding that some adults are hiding something from me is even more scary. So it's always better to let them know, to communicate openly. Honest communication in a way that children understand, especially, and in a way that other family members understand is the key. And especially when parents are the patients and they have younger children, it's important that we help parents see if they're misguided in their attempts to protect their children from harm. So one of our major roles is in facilitating open communication and expression between members and between families and treating teams. Second issue that we come across is predominantly social in nature. We talk about loss. It's not only the loss of life. There are so many other losses along with it. Yes, the loss is experienced by patients in relation to their social world, with their engagement with the world outside their home, with the roles and relationships that they have. So there is a loss of future. There is a loss of social engagements. Yeah. No going out with friends anymore. No meeting anybody. There is a loss of identity, loss of role, and loss of self-esteem, which is associated with that identity. Let's say, for example, if I'm a teacher, okay, and I'm diagnosed, loss of my role, and I have to stop teaching. Yeah, now I'm hospitalized, I have to stop teaching. The loss of my role as a teacher is associated with so many things. It comes with a loss of financial independence, loss of a meaningful contribution to society, loss of living according to my values, loss of my confidence in my role. So many things, so many different losses that we see here. Because so much of our self-concept, how we look at ourselves, is linked to what we do in a social context, who we are in a social context. In the society, who am I? And when I'm a patient, especially when I'm a patient in palliative care, and I'm not actively contributing to society, then definitely my self-image is going to be affected by it. As mobility and energies decline, it will become harder to participate in social events, to maintain friendships that were built on shared activities and interests. Social isolation is a frequent source of pain for both the patient and the carer. Now, social isolation doesn't always happen involuntarily. Some people voluntarily isolate themselves, mainly because they don't want to see sympathy in people's eyes. Yes. So for some people, what happens is, for some it is possible to an extent to get them to meet friends and colleagues. Maybe, if they're hospitalized. So what we do at the LASA is we try and identify who are the people that they would like to meet and get them to the hospital, get them to spend some time with them. But it's possible only for some to have meaningful interactions with them. For some others, the change in the way they feel about themselves and their declining functioning creates such a big gap between who they were and who they are right now, and the people they met earlier. It becomes really difficult for them to engage with those same people again. They're not able to do that. So for them, a solution might be to participate in a new social group altogether instead of trying to integrate back into old groups. Say, for example, we have cancer support groups, yeah, where they can learn from each other. They can learn how others are dealing with the changes, compare their own situation, and they can continue to feel like they are making a contribution. Especially with patients who say that they have stopped talking to people outside because they hate the look of sympathy or pity. They notice that people hesitate when they're sharing good news with me because I'm in such a bad condition, and they don't like that. They don't like that happening, or they don't like that people come meet them and don't talk about anything else but what are the possible treatments, how did this happen to you, why did this happen to you, and it's all about the illness and only about the illness. Yeah. So when that happens, the social engagements become more difficult. So they might isolate themselves, and it's always better in such cases that they connect with a different group altogether. Yes. Now, carers also have a changed identity. They might be struggling to sustain other commitments, job commitments, or other family members who also need them. They might put their lives on hold, yeah, because they're taking care of somebody who is ill. But what happens is, man is a social animal. Yeah. You might have witnessed caregivers helping each other in hospitals, striking friendships in wards, helping each other out. They do so naturally because they have a need to connect socially, right? Because they feel understood, they feel a sense of connection with the others who are also undergoing similar issues like they are. And that is why support groups can really help when it comes to social pain, when it comes to loss of social identity and social engagement. Next, we come to unfinished business. Any idea what unfinished business is? What can it be? What does the word tell you? Unfinished business.
Hello.
Yes.
Good afternoon, ma'am.
Yes, good afternoon.
Ma'am, unfinished business can be like those like whatever their personal responsibility left. Like I want to do marriage of my kids, or I want like unfulfilled desire, like whatever they want in their life.
Yes, yes. And this basically, you're very right, ma'am. Unfinished business like this, that, responsibilities that are left or things that they wanted to do, but they haven't done yet. It can lead to considerable distress, which can manifest in many different ways. It can come out as restlessness, as anxiety, helplessness, discomfort, guilt. And this unfinished business could be about their dreams, their ambitions, their plans for life. For example, building their own house, yeah, or taking care of financial commitments, maybe repaying loans, things like that. How to identify this? You just have to keep your ears open and notice. If you hear patients sounding out their regrets, you would most likely get to know about their unfinished business. Yes. For example, somebody saying, I wish I had not stopped talking to my sister. Now looking back, it seems like such a trivial issue that I fought with her over. And now when I look at it, I might not even be able to talk to her again. Why did I fight with her and stop talking with her? What does this tell you? What does this regret tell you? That reconciliation, maybe asking for forgiveness, is an unfinished business. And being able to complete that would bring some peace to the patient, right? Mostly unfinished business would be a major concern in younger patients that you see. In their prime, who have children who are small, children who are still studying, not settled on their own. Yeah, children to be married, or who have parents who are aging. Yeah, who would need care in the future. Here, the unfinished business would either be revolving around their responsibilities as a parent towards their children and as grown-up children towards their parents. In this context, the most common emotional distress would come as a feeling of guilt, of not being there for them, and anxieties about how the children will cope on their own, right? Let me give you an example here of a very strong patient whom we recently lost hardly 2 weeks back. I think this example will help illustrate all the 3 points that we discussed so far: communication, loss, and unfinished business. And it will also help you see what I mean by these factors are overlapping and not really independent of each other. So this patient, she was a lady in her 30s, diagnosed with an illness, only to know that it was in the terminal stage, that there was no curative treatment available at this point. It was sudden, shocking news for her. And she was faced with loss of identity as a young professional. She had to quit her job. As days passed and she quickly deteriorated, becoming dependent on others for her basic needs. She could not bathe herself. She needed help to walk to the toilet. So there was a loss of dignity here, which was especially painful for her to bear at such a young age. Nobody is mentally prepared at such an age, in their 30s, to take help for such things from other people. She had 2 young children, one barely a toddler who couldn't even walk yet. So she couldn't fulfill her role as a mother. Her family was extremely supportive, okay? And they reassured her again and again that they would take care of her children. So there was no anxiety regarding that per se, but there was the pain of leaving them behind, right? Not being there to see them growing up. And it was something that she was leaving unfinished. Again, there was not much that we could do to help her complete the task, so to say, right? Unlike the earlier example where reconciliation is actually possible, it's just a phone call away. But an unfinished task like this, which is a long-term task, is something where there was very limited that we could actually do about it. But what the patient did here was, she asked her child to be brought to the hospital, the elder child, okay, extremely attached to her, 12 years old. And she sat with her and she told her how ill she was. She told the child. She explained to her what a terminal illness means, what stage her illness was at, and she cried with her child and told her that she loved her and that she'll always love her. As a palliative care professional, when she told me this, my first thought was that was such a beautiful, difficult, and brave thing to do. But that was not how her family felt about it. When she was telling her daughter this, her family had tried to stop her, constantly saying that she shouldn't be saying things like this, questioning why she was putting herself and her child through this, etc., etc. Yeah, you can imagine what a family would react like when something like this happens. And that really disturbed her. And she came to me with the question of whether she was being a bad parent by doing this. But somewhere she knew the answer herself. What she told me was, I know they didn't want me to say it, but it's the truth. I very strongly needed to say it. The reason why she decided to tell her child about this was, one, she didn't want it to come as a shock for her child that one day suddenly her mom is not there. And second, she said that if I hadn't told then, I don't know if I would have gotten the chance to tell her that I loved her and that I was not abandoning her even when I was dying. That I was not going away by choice. She needed to say goodbye, and she didn't know whether she would get a chance to do that if she didn't do it now. Here comes the issue of communication. The family was trying to protect the child, didn't want her to know that her mother was going to go. But as research with children of deceased parents shows us, it is best for the child to be involved in and given a choice to say goodbye. Children cope better when they know. The ideal steps to follow for us in this situation, in her case, would have been to find out from the child what she already knew, picking up based on the cues from her other family members, to help her mother communicate with her, if necessary, reassuring her mom that this was good parenting, to give her child the knowledge of what was happening. And thirdly, helping her mother identify sources of support for the child. And this patient intuitively did all of that. Yeah. She spoke with the child. She told her what she knew about her illness. And lastly, what she did was, the patient's only request to us had been to help her child through the process of understanding the loss and supporting the child through it. That was her only request. And in doing what she did, telling the child and making the request to us, she did indeed take care of her unfinished business to the best of her ability. And when we validated her decision to communicate with her child and assured that we would talk to her, she could actually give us a genuine smile. And that was the last we saw of her. Many a times, families are not ready to have this conversation. They would rather protect the child, but what they don't realize is, by keeping them ignorant, we are doing just the opposite of protecting them. Yeah, we are not opening up doors for them to ask their doubts, to prepare themselves for what's to come, and to ensure that they don't blame themselves, which children often do. Moving on, so far we saw communication, we saw loss, we saw unfinished business, and how that can play out in an actual setting, that we don't have ideal solutions for unfinished business, but we can always do our best. We come to financial problems next. A very practical issue is financial problems. As we look into a comprehensive psychosocial assessment, we also inquire about financial concerns. Many a times, as people undergo long treatments over years without any earning coming in, it drains out much of their savings. Some might be from a poor financial background to begin with, before the illness itself. So it's a very real concern. But why are we addressing it under psychosocial issues? Is because it is a source of distress for many of them. It can even stop them from help seeking. Yeah. Because they don't have finances, they might actually not take help when they need it. There might be fear and anxiety about it, which again means that they might not respond very well to the treatment that we are giving, if these underlying causes of anxiety are left unaddressed. So talk about it. So for some who have been well off until then, receiving charity or asking for help can also become extremely difficult, and it can lead to a loss of self-esteem. So what is our role here? What do we do? One is to talk it out with them, listen to their perceptions, how they feel about taking financial help. Is there something that stops them? And secondly, to get them in touch with agencies that can provide aid. For example, at Dilasa, the place where I consult, we have the Cancer Society aid available for patients with terminal cancer. So what we do is the decision makers at admission, the decision makers are informed about it. Again, here it's important that all those who are involved in the treatment know about it. For example, we had a patient who kept insisting after admission that he wanted to go home. Okay, he didn't want to stay in the hospital. Very adamant about it. He had a young son who was working. And the nurses inquired with him whether he was not happy with the care he was receiving. Was his pain not being managed the way he expected? They were basically trying to find out what was the reason that he so desperately wanted to leave the hospital and go. Then we realized that he was troubled because he was thinking about, this is a private hospital. It is going to cost a lot and we can't afford it. And being a proud man, he felt ashamed to share this with the treating team. But what he did was he told his wife. Okay. And she told her son. Now, what the son did was he just kept reassuring the father and again, you don't think about it, I am managing it. You don't think about it, I am managing it. Which the patient felt was just a false reassurance. He felt, his salary is so low, how is he going to manage it? So, what actually needed to be done was he needed to be involved in the process of financial decision making. Once he was told about how exactly the son was going to manage it, once he was told about the aid and how it worked, how much money he is going to get from the Cancer Society and what all it will cover, he was much more relaxed and he was ready to stay in the hospital after that. So ensure that you involve the patient as much as possible in the decision-making process when it comes to the finances, not just in terms of finances, but otherwise as well, which will also help maintain their sense of autonomy in their lives, a sense of control. Moving on, we come to spiritual issues. Some of these are, again, there is an overlap. Some of them are socio-spiritual issues. Spiritual well-being, research shows, is one of the most important influences on quality of life at the end of life. Patients may experience a number of spiritual issues, including but not limited to lack of meaning, guilt, shame, hopelessness, loss of dignity, loneliness, anger towards God, feeling they're abandoned by God, feeling out of control, grief, and spiritual suffering. Now, when I talk about this, not only limited to religiosity, okay, spiritual pain is not only about religious issues. It goes beyond that. As one nears end of life or faces the reality of being mortal, or actually facing death, they might start to have existential questions like, what is the meaning of life? What is the purpose of life? Yeah. So that is something that we really need to look into. And with that, they might also start to think about the past and have questions like, what did I contribute? What am I leaving behind? You know, when I'm dying, what am I leaving behind in this world? It's important here to help them reminisce, to look at their past triumphs, you know, past victories, what they achieved in life. For example, it could be something as simple as raising 3 good children who are all of good character. And even when the person was going through difficult circumstances, or being a valued employee of that company, anything. Knowing what they did was valued is what keeps hopelessness at bay. If you don't want your patient to be hopeless, then help them know that what they did in life up till now was valued. Past trumps, knowing what they did was valued. Okay? This is a time when reviewing the past to put the present in context can be very, very affirming to the dying person. It can be done in several ways. For some people, it might just be an informal talk with friends and family, which just gives them an opportunity to go over past good memories and, you know, what all they went through and how they reached till here, and to receive some confirmation from the family and from their loved ones that their contribution to the family was valued. For others, they might require a more formal life review, especially helpful in settling anxiety and uncertainty. There are many different formal life review processes which have been developed in many parts of the world, which are available online as well, which can be used. So there are actually forms which can be used with questions to do a life review with the patient. Example, again, I'd like to give you an example of a caregiver that I was taking sessions with. What he tried one day was, he had a grandmother who was terminally ill, hospitalized, bedridden, and she would be constantly, she would be in a lot of pain all the time, and she would be crying and not really interested in anything that the nurses were trying to, distract her with or trying to engage her in. What this caregiver did was, he went and he sat and he asked his grandmother about past incidences when she was young. So how was life for you when you were my age? How did you meet your husband? Things like that. He asked her about all the past experiences when she was a young, healthy lady. And what he came and told me was, he did this for 2 days and she didn't once complain of pain in those 2 days. She was a happy person, thinking about all those good things that had happened. Yeah. So, and when we do such a review with a patient, may it be formal, may it be informal, there is a drastic improvement in life satisfaction and reduction in stress. Because when a person is so ill and so much in pain, they can't see anything beyond that pain. And when we do such a life review, they're able to actually count their blessings, so to say. They're able to look at all the positives in life that had happened. Associated with life review can also be a wish to leave a legacy behind or be involved in planning for the future of loved ones. Right? Now, some might want to have concrete gifts that they leave behind. Yeah, a painting, a sari, a recipe book, anything. A parent with young children who is dying may wish to leave a letter, an audio or a videotape for the child to keep and to refer back to as they grow up. And you can actually help them make such memory books with messages, pictures, other small souvenirs, or something personal for all the things that they would miss. Say, for example, their child's marriage, the child's graduation, getting their first job. What would they like to say to their child at that point? Could help them make a sort of a memory book or a memory box, which they can leave behind with as a concrete legacy. This kind of material, which concentrates on demonstrating the value of the child for the parent who's going to go, and reminders of times that they shared, is likely to be greatly treasured. Just imagine that somebody you really, really love, who is no more there, has left something for you, which you can go back to time and again. There are letters that they've written you. There are, there are things that they left for you. They're small things, but they remind you of them, of the memories that you had. Making a will is another formal way of ensuring that your wishes continue to carry weight after your death, right? But patients are many times reluctant to actually engage in it because they fear the legal system. There are so many different angles to it, but it's always helpful to talk to them about it and help them sort of at least think about making a will. Apart from this, spirituality, very simply put, is being connected to something greater than oneself, right? Being connected to a higher power. Not always God. Sometimes it is, for some it's God, but not necessarily for everybody. So it's not limited to a particular religion, so to say. What we need to do here is to assess the patient's spiritual beliefs, the importance that spirituality has in his or her life. Exploring whether he or she belongs to a spiritual community is something we need to do about it. Assess if spirituality is important for the person. Don't assume. Yeah, don't assume that it is going to be important or it's not going to be important. Always better to ask. Once you have asked whether it's important for them, next step is to ascertain how important or how helpful is it. A simple question is often sufficient. Is your faith or is your religion or is your spirituality helpful to you? Or how important would you say this is to you? Okay. What comes next? The next question would be, are there ways in which we can support you in your spirituality, or can we help provide you with anything or any facilities to support you in your spiritual practice? Okay. For example, I'll again give an example of a patient. A patient at the Lhasa reported that he used to visit a local temple every day in the evening. Okay. That was a part of the social fabric of his life as well, where he met his neighbors and, he could talk to them and all of that. And when we inquired if he had noticed, so when he was brought in, that we had a small place of worship in the hospital, he said yes, he had seen it. But he was bedridden, he couldn't walk. And we asked if being able to go see the idol in the evening and to sit and pray there for some time would help in any way. He said yes. It was just a matter of arranging for a wheelchair. That was all it took to help him get rid of his anxiety and distress. Yes, it was just a matter of arranging for a wheelchair to take him to the next room. It had never occurred to him that he could ask for it and that the hospital staff would be willing to do something about it. Because according to him, it had got nothing to do with his illness. Going out in front of the God's idol and praying was something completely personal for him. He never thought that actually the hospital staff would be willing to look into it and do something about it. So interventions need not be complicated, need not be about super brain science. Mostly they just need you to be compassionate and human for them to work. How does this help? How does, how would this have helped this patient that I spoke about, going out in a wheelchair, praying and coming back? For those who believe in it, concepts like transcendence, soul, liberation, reincarnation, there are so many different concepts in so many different religious and spiritual contexts across the world that can help patients deal with dying and make meaning of it. It can also help reduce suffering and can facilitate acceptance of the situation. This acts like a buffer against distress, particularly hopelessness, helplessness, loneliness, depression, death anxiety. Yeah. Transcendence, or a belief that there is a higher power beyond human existence, enables feeling connected. It removes the isolation of suffering. Why me? I am alone in this. That feeling is gone. And so religious traditions of the world have their own interpretations of suffering. And many of these have practices that enable people to transcend their pain and transcend their suffering and their immediate selves through prayer, through meditation, through different rituals. And they acknowledge the reality of suffering, but they also point towards an ultimate goodness of the universe and fulfillment of the human soul beyond suffering. Even for the family, rituals following death, post-death rituals, we have them, they're universal, right? Everybody has post-death rituals. This is how the family makes sense of their loss. These acts of remembrance can help in processing grief. But when we see that, yes, spiritual practices do indeed help, and how they help, it's extremely important. You need to make sure that you're not letting your own beliefs interfere. Yes? You're not pushing the patient in any way to engage or not engage in spiritual practice. It is our job to respect the patient's spiritual orientation or a lack of a spiritual orientation, and to encourage spiritual practice if a person is already engaging in it, or only if a person would like to engage in it. We are not going to push those who do not. Okay. The only thing we're going to do is ensure that patients are given the opportunity to express their spiritual beliefs and practices if there are any. Next is grief and bereavement. Grief is the emotional response associated with loss. It's an inevitable thing, right? It's an adaptive adjustment process. So it's not always that an intervention is required. For the majority people, although bereavement is painful, their personal resilience will ensure that they normally adapt to this change. So we need not actually have an intervention, so to say, because normal grief is not pathological. But as the patient and family journeys through palliative care, the clinical phases of grief will progress from anticipatory grief to acute grief, a normal grief reaction, and for some of them, there might be complications of bereavement. Features of normal grief are emotional waves of distress, unavoidable crying, preoccupation with the thoughts about the one who has died, reduced concentration, somatic symptoms like restlessness, numbness, weight loss, fatigue, behavioral symptoms like seeking consolation, social withdrawal. All of these are normal, okay, after death. Here, we just need to be a supportive presence. Let them know that we are available to help if they feel the need. But sometimes active intervention is required when we see some abnormal patterns of grief. What is anticipatory grief? Anticipatory grief is before death. It results from the expectation that a death is going to come. Yeah, that is what makes the person grieve. What happens here is there might be some common difficulties which can emerge. There might be impaired coping where family members might deny the seriousness of the illness. They might withdraw, not be involved in the treatment process, or they might show anger when there is anticipatory grief. Our role here is to encourage expression of feelings in anticipatory grief. Help them express openly, help them recognize that saying goodbye to a person is a process. And in this process, on this journey, there are going to be opportunities to celebrate the life of the patient, to express gratitude, to take care of unfinished business and reminisce on the way. Yeah, so there are positives on the way. When it comes to complicated grief is a pathological outcome involving psychological, social, or physical morbidity. It's prolonged grief with difficulty accepting the loss and meaninglessness even post 6 months after the death. It's associated with poorer physical and mental health outcomes and increased suicidality in those who are left behind. This is when active intervention is required. Inhibited or delayed grief is another avoidant form of complicated grief where immediately the person might not show any grief. It might seem like the person is absolutely okay, and the grief might come at a delayed state later on, much later. Complicated grief is more likely when the death is traumatic or untimely, sudden, when there is a lack of support systems in place, and when there are previous vulnerabilities, or in case of dependent relationships that they had with the person who is no more. We also have what we call disenfranchised grief responses. This is what we call the hidden sorrow of those who are marginalized, for whom there is less social permission to express, yes, to express their loss. For example, homosexual partners, yeah, it might not be, especially if the relationship is hidden, then we might have disenfranchised grief. Or when there are extramarital relationships, there we might see disenfranchised grief, hidden sorrows, yeah. Next, we come to psychological issues. These are what we very commonly know of, right? Anxiety, depression, body image issues, especially when it comes to cancer. Body image issues, very, very commonly seen, including a loss of attractiveness, issues of self-esteem and self-worth, again, which are related to your body image. But we can put all of this under the umbrella term of distress. What is distress? An unpleasant emotional experience of a social or psychological nature that is tied to and interferes with the ability to effectively cope with illness and illness-related treatment. what happens here is making psychiatric diagnosis and rapidly identifying patients in need of help is difficult in a palliative care setting. One problem is the psychiatric symptoms may be mimicked by the side effects of medications or the disease process itself. So we don't know whether it's the disease or is it a psychiatric comorbidity that's coming up. Here, I think this would actually help. You could also take a screenshot if you want and keep where it could help you identify clinical diagnosis of psychiatric disorders, so to say, mainly when it comes to anxiety, adjustment disorders, and depression. All right. So we need to take all these into consideration. I'm not going into the details of that because we're short on time. But mainly there is a lot of underdiagnosis and under-identification of psychiatric disorders, highly prevalent in palliative care, mainly because it's not recognized by professionals who are not psychiatrists. Yeah, so not recognized by doctors and nurses who work in palliative care. So being able to identify and assess is very important for all of us. And in a drive to address this in the context of cancer care, NCCN, the National Comprehensive Cancer Network in UK, what they did was they promoted development of brief and rapid screening tools. Yes, which could be administered by any professional, need not be a specialist. Okay, and the distress thermometer is something which you can definitely use, which could be helpful to assess psychosocial issues and distress related to that. It's again freely available online, you could use it. Depression is something which frequently remains unrecognized and untreated because we dismiss it as normal reaction. Yeah, we feel that a person with terminal illness is going to feel depressed. The most common diagnostic difficulty comes when we have to interpret physical or somatic symptoms that patients present with in the context of a possible depression. The challenge here is to determine whether these symptoms are part of the depression syndrome or a biological result of the illness. But the thing is, it's always better to be on the safe side, to be suspicious and refer to a specialist, instead of thinking that it's not a psychiatric comorbidity. Occasional thoughts of suicide are also quite common, but if they're frequent, if they're persistently present, then it might indicate the presence of a psychiatric comorbidity, a psychiatric complication. Many a times when assessing risk and intent, what we need to do is we need to just acknowledge that all they're trying to do is have control over their own death. Again, nursing staff have an important role in identifying patients who may have psychiatric symptoms because nurses spend more time in direct patient contact. It enables them to observe behavior more closely, and it gives an opportunity for patients to express any psychological distress to the nurses. So nurses may not be able to identify specific disorders, but you're definitely skillful in recognizing significant distress when you see it. So don't wait for yourselves to confirm that this is a psychiatric disorder. The moment you see distress, make sure you're doing something about it. Yeah. Again, how can we establish that a patient requires further treatment assessment? There are so many different preliminary screening measures like the distress thermometer, which I just showed you. Apart from that, there are scales, which are clinician rating scales, which clinicians use. For example, the Beck Depression Inventory or the Edinburgh Depression Scale. But make sure that you are taking into consideration that you're taking a specialist's opinion into consideration before using any of these scales, mainly because not all of them are valid. We need to use them with discretion. Okay, so some of them are useful in palliative care, some are not. And in case of palliative care, many a times what happens with rating scales is, one, patients are not willing or they're not able to discuss their symptoms. And asking caregivers, we might do that, we might ask caregivers that, how is that person feeling? Are they crying? Are they doing this? Are they doing that? But that is extremely unreliable because Research shows that ratings of caregivers are closer to their own distress rather than the patient's distress. Okay, so it's colored by their own experience and their own perception of the illness. So it's always better to not ask or not solely depend on what the caregivers are saying. One very simple thing, simplest and most effective. It might sound unreal, but research shows that it's one of the most reliable predictors of depression, and that is directly asking the patient, are you depressed? Seems very weird, seems very counterintuitive to do. I don't know how is this possible, but it shows that asking this one simple question, not followed by anything else, is the most reliable predictor of depression. You will get a 100% result of yes when there is depression. So it's definitely helpful to assess at admission, but always keep an eye out for appearance of new symptoms, just like you would do for physical symptoms, right? So similarly, also keep an eye out for any kind of psychological problems or complications that you see coming up later on, once admission is done. Okay, and all members of the healthcare team, what they need to do is they need to observe and report distress that they feel is psychological in nature, like fear or anger, or is psychologically mediated. For example, pain or breathlessness, where having a psychological complication might exacerbate the pain or exacerbate the breathlessness. This might or might not meet the criteria for a psychological disorder, but regardless of the etiology, regardless of the diagnostic label, it is ultimately about the patient's subjective distress, which we need to help with. So we need to report this. And apart from distress, our work is not only to identify problems and distress, but also to see and help patients see their current support systems, which can help with the distress, and their internal personal resources and coping strategies, which are their strengths in dealing with all these issues. What ultimately, summing up, there are some final pointers about what our patients need, what your patients need. The need for understanding, need for acceptance, need for self-esteem, need to feel safe, need to belong, need for love, for spirituality, and ultimately for hope. And in the provision of psychosocial care for people at the end of life or in palliative care settings, each of these needs must be identified and addressed. As you see, most of these needs are not about you being able to provide technical therapeutic expertise, but they are about being a non-judgmental, compassionate presence who is witness to their suffering, who is giving them space to express their distress, and who's accompanying them on their journey, who's trying to help add life to their days, not simply add days to their life. That's all I wanted to say. These are some final do's and don'ts that I think are pretty much self-explanatory. You could go through it. Make sure that you're respecting people's rights. Make sure you're not bringing in your own biases, being honest with them and keeping things confidential. You're not making false promises, not pressuring people to tell you their stories, and not judging them. Yes, ultimately, be a compassionate, non-judgmental presence. Take care of your own stress levels when you're doing this, because palliative care is not easy. Definitely, it can take a toll on you. And as I said, add life to their days, not just add days to their lives. Yes, thank you very much. And I hope you got at least some insight into the psychosocial issues that can happen in palliative care. Thank you.
Thank you, Mukta, for the wonderful presentation. And also you have shared some patient story too. So thank you for that. So anybody has any questions regarding psychosocial issues, please ask her. Either you can unmute yourself and ask, or you can put your answers in the chat box. The questions, sorry, questions. Anybody? So I think nobody's have any questions. Now I hope they have clearly understand about psychosocial issues in palliative care. We have to understand that, as Madam said, we are the as nurses. We are the persons spending more time with the patients. Okay, we have a lot of time, so we are the persons to find out whether the patient is having psychosocial issues or not. If the patient is having psychosocial issues, you have to report to the psychologist or a medical social workers and try to elicit their actual problems and try to relieve their problems. Then only you can so as your goal, right? Because if the patient is having physical problems, definitely if they our aim is to control the physical distress. The first aim is to control the physical symptoms, pain and other symptoms. So through that we can able to improve the quality of life. But on the other side, if the patient is having psychosocial issues there, we are not able to control their physical distress fully. So I have a lot of experience. If you increase the dose, if I have one patient who is having hepatocellular CA, and he was not getting adequate pain relief. Even we increased the dose, the morphine and all, so he was not getting adequate pain relief. Then we sat and discussed with his wife and explored their psychosocial issues. Then we found lot of psychosocial issues in his life. So then we try to meet that psychosocial needs, like children's educations and all. So then his pain score comes down. So that is very, very important. If the patient is having psychosocial issues, your medication is not much helpful for that patient. You have to try to relieve that support and try to relieve that psychosocial issues, and then you can that way we can improve the quality of life of the patients. And this is very, very important. Without a teamwork, we can't do anything. So we need to we need a good teamwork for improving quality of life of the patient and their family. Okay, so can we move on to the patient story? Okay, so Ms. Jaya Sharma will be presenting a patient story today. Ms. Jaya Sharma, over to you.
Yes. Thank you, ma'am.
Continue.
My patient is 35 years old female. She was diagnosed as a case of metastatic CA breast, and she was admitted with recurrent ascites. She was admitted with presenting complaints of ascites, pain abdomen, nausea and vomiting, generalized weakness and bone pain. And the date of admission was 23rd February 2022 at Command.
Ma'am, you are muted.
Sorry. Next slide, please. Coming to the history of illness, as I've already told, she is a wife of a serving soldier. The onset of disease was in April 2020, and the mode was she had lump breast while lactating after delivery of the second child. I would like to add one point here. My patient, she was diagnosed when the disease was advanced, as when she has reported to the hospital on OPD basis during the time of lactation. It was thought to be a fibroadenoma and enlarge and the engorgement of breast, and FNSC was also negative. So this was the mode, and the personal, when we come to the personal history, there is no any other comorbidities or chronic infection and no other history of any medical or surgical illness. Even the family history, there was no malignancy reported. Next slide, please. On examination, during the physical examination, as you can see the height and weight, and she was thinly built and undernourished. Though she was afebrile, but tachycardia was persistent, ranging between 128 to 132 per minute. Respiratory rate was bit high, that was 34 per minute. BP was on the higher side, 130/70, and SpO2 was 98 at room air. On general examination, patient was well-oriented, conscious, and cooperative. And skin and musculoskeletal system, there was no abnormality was detected. In cardiovascular system, pulse was regular, tachycardia was present, S1, S2 heard, and JVP was not raised. In respiratory, bilateral air entry was present, though tachypnea and shortness of breath was there. On per abdomen was distended, no dilated veins, tenderness present at the site of pigtail insertion. Bowel sounds could not be appreciated because of the distension. In CNS, she was alert. GCS was 15/15. Speech was normal. Memory intact. All
Ma'am, again you are muted.
Ma'am, you are.
Yeah, ma'am. Yeah.
Next slide, please. Now the treatment and significant investigation. As she was advanced CA breast, she was diagnosed with advanced CA. So she underwent bilateral oophorectomy in June 2020 and toilet mastectomy on 19th October 2020. She received first cycle of adjuvant chemotherapy. Adjuvant means before surgery. Just to shrink the tumor, we start with the chemotherapy, and she was given till 15th of June to with effect from 15th of June to January 2020, along with injections zoledronic acid, some CDK inhibitors and letrozole was given. Then she was started with the palliative chemotherapy. So in palliative, other things we have given the second line, third line, and fourth line of the chemotherapy, and then reassessment was also made in between, where she was found to have liver lesions on both sides of the both lobes of the liver, and skeletal mets were also there, which was suggestive of disease progression. Then third line and fourth line was given subsequently. Presently, my patient is on fourth line of palliative chemotherapy with lipodox and denosumab, 4th weekly. Next slide, please. And this in the significant investigation, we can see that PET scan dated 21/1/22. There was post-mastectomy status, and mild diffuse pleural thickening was there, multiple nodes in the right axilla, and minimal pleural effusion, multiple hepatic nodules, and multiple cystic lesions in the skeleton. So we can appreciate that the disease was progressive. And in histopathology report, which was positive, was invasive carcinoma, where ERPR was positive and HER2 was negative. Then the repeat biopsy from the hepatic lesion was done on 15th February. There was no evidence of malignancy was there, but after 6 months of follow-up, again liver biopsy was liver lesion. Next slide, please. Now, these are the investigation where you can see here hemoglobin was 7.5 also. In that case, we have transfused the blood also, and due to the hepatic lesion, her serum bilirubin was also on the it's raised. Now, these are the medication, as I have already mentioned. First, second, third, and fourth line of chemotherapy was given. And other than this, she was on tablet Altroxin 50 microgram OD, as she was a case of hypothyroidism also. And for domperidone and MCET was ondansetron was given, as she was on fentanyl patch 50 microgram 72 hourly, and due to which she was having nausea and vomiting. Then just to because of fentanyl and all, she was having complaints of constipation. So syrup Dulcolex was also given. And for the pain management, tablet PCM 650 mg TDS was also given, and ranitidine. And because of the pigtail, what we have inserted, pigtail insertion was done due to recurrent ascites. So there was an infection, and we have removed the pigtail, and for that injection ticoplanin 400 mg OD and tablet linezolid 600 mg BD was started for her. Now coming to the psychosocial aspects, the main problem was with us was that she was from Andhra Pradesh. The language barrier was there, and she was far away from her native place. She has 2 small kids, and they were at Andhra with grandparents. Husband is serving in army, so his duties were also affected, and no one else was there to support for the long-term treatment, because in cancer or any other diseases, long-term treatments is required. And she was not able to have proper diet due to illness and change of place, because in army setup we mostly give we have central cook central pantry. So from there food is provided, and she's language barrier was there. She communicates in bits of English language. So whatever the communication I used to have, it was with the body language, or I used to understand, or I used to talk with the husband, and then he used to translate her. So for health education for palliative care and supportive management, it needs to be given. Next slide, please. Now the main concern was progression of disease as it was detected at advanced stage. She was having recurrent ascites, and due to which she was having shortness of breath, then nausea and vomiting. It may be due to the ascites problem, then disease progression, and plus the fentanyl or the pain management which we were giving, and through the sepsis also, because pigtail infection was also there, and the culture was positive for E. coli. Then anemia was there due to poor nutrition. Already she had mets to liver, lungs, and skeleton. She was prone to have spinal cord compression and seizures, which is like spinal cord compression is also oncological emergency. And she could carry out her daily activities, but only with support. Next slide, please. Now to summarize my case presentation, 35 years old, wife of serving soldier, was detected with breast cancer, right side in April 2020. She underwent surgery in June 2020 with bilateral oophorectomy, and in October she had toilet mastectomy, started with chemotherapy, had disease progression with metastasis, now on palliative chemotherapy and supportive management. She was discharged of 1 week before, 1 week earlier only from our hospital, and we made her husband and her also to realize that now it's a good time when your senses are fine, and you should meet the family members, and whatever decisions you have to take, it's the best time. And we hope that she will come back for the 3rd cycle of chemo, which is due on 8th of April of this year. And so to discuss, first of all, the pain management, though we have controlled with it with fentanyl patch, but 50 microgram is too much. and then to control nausea and vomiting. So for the 24 hours, she has to have more of nausea and vomiting, for which injection ondansetron was also given, and tablet domperidone was given half an hour prior to each meal. Then to relieve constipation, then nutritional buildup. For that, we have consulted the dietitian, and high calorie and high protein diet in a soft form was advised to her. Then individual counseling was given, and then family counseling. Individual counseling was not very effective from our side because there was a language issue. But yes, family counseling was given, and she was a she was a teacher in a school, so she knows about her disease and she's very well versed about it. And through her body language and everything, it was like it was very clear that she knows that her disease is progressed, and she is on the supportive management, and her husband is also being clarified about the things. Thank you so much.
Thank you. Thank you, Jason, for presenting this patient story today. So anybody would like to need any more clarification in this patient story? So otherwise, we can move on to the discussion points. So you can think from the patient side itself. 35-year-old woman suffering with advanced CA, multiple metastasis, having 2 small kids. So
This time
you
I have
yes.
yes, ma'am. I want to add one more point. This time I have explained her husband also to make her elder child, who is 10 years old and she's a girl, to make her understand that your mother, that her mother is not well, and so that she can be well prepared for the upcoming problem, which is likely to come within 6 months or so. So because that a younger one is just 3.5 years old, so there is no point explaining her. But yes, elder daughter can be explained.
Okay. Thank you. Thank you. That is the very good thought. So she has to at least the eldest daughter has to understand about her mother's sufferings. Okay. So that is very, very important. Anybody have any suggestions or comments on these patients about the treatment or anything? Mukta? So to you.
Okay, first of all, I hope that, after the presentation we had today, and when you look at the case, you might have been able to identify all the issues that we discussed. So, you see a lot of, as you said, she was a teacher, now she's not teaching anymore. So we see that there is a loss of role. We see that there is a loss of her identity, so to say. And we also see that there is a lot of unfinished business, considering that, she's so young and there are 2 kids who are so young. In this case, I think it would always be helpful to actually ask the patient herself what she would like to do with the time she has. Especially when the patient is aware that it is, at such and such a stage and everything. She might not be aware that it's actually terminal or whatever, but even knowing that it's a serious illness, she'll definitely have, sort of a bucket list where there are things that are on her priority list. It's always better that we don't assume what's on her priority list, and let her decide. We can always look at feasibility. We can always look at what is possible practically, what's not possible practically, and discuss it with her. But it's always better that she comes up with what she wants.
Rightly said, ma'am. Actually, though I'm working in onco ward, and
Yeah.
most of the times it happens that I don't have guts to say that now things are going to be like everything is going to be end, and then you start thinking. But yes, to the relative, I always explain. Like for her husband, but I have explained her husband that it's a good time when she can speak, when she can hear, when she can see, and it's and many things you have to decide about the future of kids and whatever things. So this
Right.
is the best time you can go and you can discuss among yourself. So, and there was a language problem. Otherwise, I would have spoken to her, because I remember one of my case. She was 28 years old lady, though she didn't had any kids, only 2 years of her marriage. So she's no more now. Actually, I remember her when she asked me, "Ma'am, aap batao ki whether I will be fine or not." So I didn't had any answer to it, and I said, "You must be knowing better than me, better than a doctor, or better than your husband. You must be knowing better." So I told her, "Don't think so much. Whatever time is there, we are for you, and it's okay. It's like, actually I don't have guts to say to my patients that you will be like no more now."
Yeah. No,
Yes.
these are difficult conversations. These are definitely very difficult conversations. But yes, at least in some way preparing them for what is to come. Even, as you said, you might not have said it directly, but from what you say and your body language, the patient does guess.
Yes.
Yeah. And
So
it's true in a way what you said, that the patient knows best because they can feel it.
and
They
the
feel
day
it personally.
and the day I told this, the second day she was like, she left us, because I cannot give them false hope that you will be fine, absolutely fine.
Right. Right. And it's always better not to. Don't give false hopes, false promises that you will be all fine, you will go back home walking. No, we tend to do that just to, I think it's more than comforting the patient, we are just comforting ourselves when we do that, because we don't want to have that difficult conversation and we don't want to deliver the bad news.
And it sometimes happen, ma'am, language issue is also there. And this
Yeah.
lady was from
Yeah.
Andhra. So
Yeah.
only which I could relate, like vomiting, pain, are you okay? Only this much I used to talk to her.
Right. And I think also, considering her age and everything, it's always also better to screen for psychological complications, especially because when it comes to nausea and vomiting, this is what I said, that it gets complicated here, that we are not able to take out that this is psychiatric and this is the cancer. Mainly when it
Exactly.
comes to nausea, vomiting, breathlessness, and their subjective rating of pain. How much pain do they feel? So this can definitely get affected by uh, some kind of psychiatric complication which can arise, and it's always better to just screen for it, because as Shiva ma'am also said that then however much you increase the dose, it's not really having any effect because there are so many other factors.
Exactly.
Yeah.
Thank you, ma'am.
Anybody have any comments? Others? So time up. I want to discuss more about this patient, but we have another session is planned for 4:45 p.m. So we need to wind up now. So I'll talk to you later, ma'am. So regarding this patient, I want to talk to you. So try what we need to do more with this patient. Okay. So thank you. We can wind up the session. Thank you all for joining this session. Thank you, Mukta, for the excellent presentation. So we have learned more from your session. And thank you, Jaya ma'am, for the excellent patient story. Thank you once
Thank you, ma'am.
again. Thank you. We will meet you coming Thursday. Okay.